atop Caesar Rodney Square in beautiful downtown Wilmington, Delaware.
We are the Podcast Pediatricians. I'm Matt Gotthold.
And I'm Rob Walter. Check us out on iTunes, Spotify, Google Play, Podbay, and podcastpediatricians.com, where you can leave your email and receive alerts directly from us. Happy New Year, Maddie.
Oh, Happy New Year, man.
How was it? How was your New Year?
Good. Excellent. Got to see the family.
Quiet New Year with Susan at home, but a little New Year's story. You know, Lila Rose, my mom.
I thought that was your mom.
Turned 90 last
Happy
month.
birthday,
We had a great party.
Mrs.
So
Rob.
I always call her after New Year's, like a couple minutes after the ball drops, and I called her. I'm like, "Happy New Year, Mom," and she sounded so upset. Now, for my mom, she could sound upset if the cable TV doesn't work or if like her best friend died. It's the same amount of like, ugh. So what's wrong? Said, I missed the ball drop. Why? Well, I was watching CNN because she loves Anderson Cooper, and they missed it. You heard about that?
No.
They missed the ball drop. They were like in Nashville, and they came back, and I was like, it's okay, Mom. You'll get it next year. She's like, what if I'm not here next year?
Oh, my.
And then, like, I was like, no, you'll be here. But, you know, you're 90.
Yeah.
And you watch those things, you think, like, you know what? How many more New Years do I have?
Yeah.
But
Yeah, it's
she
funny
will-
when you get to that point of your life where you start thinking about that.
How many
right?
left?
I'm not sure. There are calendars out there where you can kind of mark off your, like, how many weeks do I have left to live? I don't know. I look at them kind of like the things that can tell me whether I'm going to have, like, you know, Parkinson's disease or something, right? I kind of rather not know.
Yeah, that's not good. All right, Maddie, hit us with a disclaimer.
All right. So we are sharing our own personal opinion on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care. So how's pediatric practice treating you these days, Roberto?
Well, I'm on call this weekend. You're not, so I'm jealous, but I'm kind of steaming. I got back from doing babies this morning and was discharging like a 21-year-old first-time mom, and I asked how lactation was going, and she's having some issues, and I asked her what the lactation consultant said. She goes, hadn't seen one. Went out to the nurse office and said, what happened to lactation? Oh, it's not automatic with first-time moms anymore. That's not considered a
Since
high
when?
enough level. Since like last week.
Thanks for the heads up.
No longer do first-time moms make level 3 or whatever that qualified early, which is insane. Who needs
First-time moms don't make it.
who
like,
needs
who
it
does?
more than
Right.
they do?
Uh-huh.
There may be some staffing issues, I know, but that's insane.
Oh,
So
my
they say, but if you
goodness.
put it in order, then you can probably make sure they get it. So like everybody's getting an order from me. It used to be automatic, but I don't know about you. But
That's not baby-friendly.
that's not baby friendly. Otherwise, I think both of us are finding that the
Yes.
sick visits are really coming down.
Yeah, it was quieting down. Now
It
it's
is.
picking back
A
up
lot of
again.
ear infections. I mean, ENT guys are buying their
Yeah.
second homes because they're going a lot. There's a big waiting list for them. And they were seeing some strep, but the RSV, influenza is going down. Haven't seen as much COVID, although I just noticed that my Northwestern Wildcat basketball team's game last night against the Badgers was canceled because of COVID. And that made me think of, remember when this all started? In the like March of 2020, like the first sign that something bad was going on is they started canceling sports
Yes.
games. You're like, okay, this is serious now. The sports games.
It's the
So-
harbinger of bad things coming. Right?
I know. And how about your practice? How's things going?
Yeah, so we are seeing a lot of strep. We're also seeing there's a stomach bug going around, which I'll be honest with you, it's been a couple of years since we had that kind of a thing go around.
The
right?
vomiting.
Mhm, yeah.
Vomiting.
The
Yes.
vomiting
I had
is
a few calls
horrific,
already
yeah.
today about just vomiting.
Yeah, and that's, I mean, I understand. That's very disconcerting to parents, right? But I actually had a dad call me last time I was on call, and I thought it was, initially, I was kind of like, what do you call me now for? Because his question was, okay, my wife and myself both have this GI bug, and we have a baby at home who's 2 months old. So I'm calling ahead of time to find out what I'm supposed to do, and when I take him to the hospital. It's like, so you're calling me about a problem you don't have. But then I thought to myself, but actually, thank you. That means you're not going to call us at 3 o'clock in the morning, right?
We appreciate that. We appreciate that. Hey, speaking of the vomiting, so we've talked about generic Zofran, ondansetron, and how we use it more and more for gastroenteritis in the right settings. Have you sometimes prescribed it on call by phone? Because I have.
Yeah, there are a lot of things that I have become comfortable with over the years doing on call that used to be anathema to me when I first went into practice, because you want to be careful, and you want to, but after you've been doing it for decades, the
family,
like you and I have, and yes, I'm willing to call in ondansetron for that.
Ondansetron.
Oh,
Let's call it generic Zofran.
I like ondansetron.
Okay, you
because it's dancy.
Listeners, Matt's dancing now. Luckily, we're sparing you that visual of that.
Yeah, but I've done that, and I've definitely done more steroid for croup over the years.
Right, I just did that this morning.
Yeah,
low dose, a few days.
Low dose. And actually, I'll usually go relatively high dose, so I'll go 2 per kilo divided twice a day for 3 days. But also warn them that
I'm half of that dose.
That's okay. Yeah. Your patients just come over to my place when they can't get better. I haven't given you a shot like that lately. I think it's imperative, though, when you're telling somebody this kind of thing, and we'll get to this in a minute, that you're clear as to this isn't going to cure all their symptoms of this virus, right? You have to let them know that, and then within the next several days, it's going to roll into what you'll recognize as a routine cold, and that's going to be 7 to 10 days. So this steroid is not miraculous.
When they're getting some stridor at night, and it's going to be the second night's worse, this could really save a lot of pain. Another thing that I haven't been doing much, but we both are dealing with, is people calling high fever, we can't find Tylenol, or we can't find, ibuprofen. And I had someone the other day, and I said, well, get a tablet and crush it up and put it in chocolate syrup or an applesauce. And we talk about what the right dose would be for that. And then I go to the front, I'm like, I just winged that, but can you do that? So then I, Dr. Google looked at it and said, actually, yes, for the tablets, but it's not a great idea to open up capsules.
Right.
So we don't do it for that. But that is one. Then there's also rectal Tylenol, the Feverol, but only it's like 80 milligrams.
Yeah,
so,
and it's hard to track down sometimes, and then you have to remind, just what you said, you can take the chewables if they can find those, and not others, and just crush that and give it to your baby.
Exactly.
Right?
So
no, we have to get creative when there
and
are
this
such
week
shortages.
Also, I thought we were over it, but I got an 11-month-old mom of 11-month-old who couldn't find formula. And she had run out.
Oh, boy.
And she's like, can I give regular milk? And so we both talked about that it's not ideal. We talked about waiting till a year. But yes, in a pinch, you can give whole milk and likely be okay. We worry about GI issues.
Right.
And then try to find formula. But I thought we were over that. But I guess there's still pockets of
there are
shortage.
pockets of a lot of things. I mean, some of the stimulants have been hard to get a hold of.
Oh, my gosh.
The Adderalls and the long-acting methylphenidates have been difficult to get a hold of. And what's really irritating, Rob, is that, okay, you have all these providers out there. I mean, how many pediatricians are there in Delaware, right? Probably 200, right? At least, who are out in private practice, right? So you send us things, pharmacy people, you send us things that say that we need a prior auth and this and that and the other. Why don't you just blitz us with something first thing in the morning that says, these are the medicines we're out of? Right? It's really, my staff has to call every day. Do you have it yet? Do you have it yet? Do you have it yet?
And then some say, no, we will only take brand.
Right.
And then they'll say, no, we only take that. If you don't check the box or not check the box. Yeah. And I also, it's interesting because, we've talked about, I'm a little bit more of a Concerta guy than an Adderall guy. I like Vyvanse, but for the methamphetamine, something about the Adderall really gives a kick. There's a little bit of a issue. I worry about dependence.
Yes.
Teens were running out of Concerta. It was an issue. They called us. We worked on it. When they were running out of Adderall, it was like, we need our Adderall now. It gets to the point that I really worry about Adderall.
I'm really careful with it as well. I only have a handful of kids on it, and mainly because I don't want to put them in a situation where their peers or themselves are tempted to abuse it, especially as they're teenagers kind of moving along to college where it's heavily abused.
Right. I started my week off this week. On my desk was the positive chlamydia result. That's always a fun
that's a fun
call.
Conversation.
You notice when you call back a college kid especially, first of all, they never answer.
No.
And their mailboxes are full. And it's not like I want to call their mom and say, hey, trying to get your son. I don't want to tell you what it is.
Jimmy has a little something.
A little something. So
something.
It just gets back to how different our practice. Yes. You mentioned other things like starting topical timolol for hemangiomas or doing PrEP for a young man to prevent HIV SSRIs and cross tapering. And by the way, there's a great application, or it's online, called switchrx.com. Have you heard of that?
No, I've not.
Shout out to Dr. Christina Lahane, who gave me it, where you can just put in the different meds you want to switch to on SSRIs, and it goes over how to do that, even other things too, and ADD meds. So if it's not for someone who doesn't know the logistics, but if you know how to do it
already,
then it really is helpful. So switchrx.com, we have no connection to them.
Yeah, I mean, I think that you probably largely went into medicine, and specifically in the pediatrics, because you wanted to be a lifelong learner, right? And so we do find ourselves, I think to myself sometimes, like, well, nothing's really changed all that much in the 30 years we've been in practice. But honestly, it has. But just in tiny bits and pieces that we didn't appreciate, right? It's like turning around and all of a sudden your child like grew 2 inches, right? And you're like, oh man, I didn't notice that, or 2 feet, right?
Right.
Yeah, I think one of the things that's imperative that we focus on, and I don't think enough of us in the profession do, is clarity, right? I think that people are loath sometimes to have us clarify what we mean by certain things because they're either embarrassed to or think they understand. But the primary thing here, and we've talked about before, is inhaler use, right? I mean, we'll prescribe an inhaler and somebody's been using it off and on, and then how are things going? And we'll see them periodically for rechecks or for their well visits. And everything seems to be going well until suddenly they're not doing so well, and you bring them in and you say, okay, let me see how you use your inhaler. And then invariably it's wrong, right?
Exactly.
Well, no wonder you're not getting any better, right? And so I really think that the onus is on us to make sure that our patients understand clearly what we mean when we say things.
And they bring it in on the well visits so we can keep watching their technique.
Yeah. No. I just saw a young lady, 12 years old, and she's been followed by my practice for quite a while, but she's been seeing a pulmonologist and an allergist since she was about 2, right? So we haven't really gotten heavily involved with her management. And she was in the midst of having an asthma exacerbation. And I said, okay, I want you to use this inhaler. Completely wrong, right? Oh, the mom was livid.
Like a breath spray,
yes,
right?
Yes. The mom was livid. She's like, I said, how long has she been using it that way? She said, like, since she was 3, right? So no wonder, right?
Wow. We're actually thinking about doing our own PFTs.
Yes.
Spirometry, the company that has one came out. I won't mention them, but are you also? We should
You know what? We've done that off and on.
Yeah.
Like we've had somebody out, we've used the machine, and either it was lack of interest or lack of opportunity, or sometimes it was actually lack of, again, clarity in terms of being able to explain to people how to do this. Do we really want to get into that sandbox?
All right, we've gone on many tangents here, but let's bring it back to our topic today, which is lipids or fats. So grab some potato chips. Philly's own Hers, I think. Is that your favorite?
It's my go-to. Yeah.
Nice.
My favorite lately is Voodoo chips. You know those from Wawa? Oh, yeah.
No,
But you can get them much more readily down south. Oh, they're super crunchy and super spicy.
And we're going to talk about healthy eating, but we love a Wawa.
Oh, damn.
Oh, if you don't know what Wawa is. And have you ever been to the Hers potato chip factory?
I haven't.
I haven't either, but my kid, right.
Yeah.
It's a staple of Delaware kids. They go to the potato chip factory, and then maybe get some fries.
Not sure what that says about our education.
And then my best fries are probably, now we talk about healthy eating. Five Guys, my favorite fries. And now we're going to talk about hyperlipidemia.
Gotcha. Well, wait a minute. How about, we've got to slide this one in, man. How about those Eagles last night, right?
Was there a playoff game last night?
Oh, was there? Oh, yeah. It was the one where we slammed the New York Giants.
Oh, my gosh.
Not the most hated of our rivals, but certainly second tier.
Yes.
That's right.
Yes. And we're all like holding our breath because it's Philly. Like, what if Jalen
Rob and I
Hurts'
are
his shoulder
texting each other,
falls
right?
off?
And the Eagles are leading by like 28 points, and we're still not comfortable.
No, not comfortable at all. So
crazy stuff.
It was amazing. Are you? And next week, Matt may go.
I may. I have season tickets, as does my brother, and my brother was generous enough, and I decided to give them to my kids so they could go last night because they'd never been to a playoff game, and they were thrilled. Absolutely thrilled. It was a great day.
That's a great dad. So, we talk about football. I think we would remiss if we're talking about football. What was the huge story in football in the past month? Was that Monday night game a few weeks ago with that horrific live cardiac arrest of a young 24-year-old athlete. It kind of put everything in perspective. But if you think about it, you could say, what a tragic thing. But how lucky for that guy to have a cardiac arrest on national TV with 30 physicians like around and multiple AEDs around. I mean, if that had happened in the off season when he was taking a run someplace, he wouldn't be here. So we have talked a lot about violence in football and whether teens should play. That was a big hot topic back in Disney World a few years ago. And because of this issue, is interesting. Of all the other things that happen and concussions, this was the first time that I had some parents the next week say, hey, I'm thinking of not having my kid play football. And this one teenager who was like a ninth grader was really not happy. Have you gotten some of that feedback?
A little bit, but I think it's like most things medicine. Something gets an awful lot of press, and suddenly it becomes a concern, but maybe not for the right reasons, right? So I think that the issue in terms of Damar Hamlin, I have had some feedback about. There are multiple debates to be had about the wisdom of football, as you just said. But in this case, I don't think that an extraordinary event like this, that this can be interpreted as representative of the risk incurred by the sport of football, right? The specific play itself was not notably more violent than those routinely encountered in any contact sports, right? There are plenty of reasons to argue about the safety of playing football, but this rare event's not a legitimate argument, in my opinion.
I agree.
Mm-hmm. As of this taping, investigators have not announced any details on the source of Damar Hamlin's cardiac arrest. As pediatricians, it's easy to speculate on the possibilities, but would be unjustified to presume that the true cause is a certain thing without any evidence to support it. We both hate it when doctors provide armchair diagnoses, based on reports from the general media. We do think it's reasonable to consider the known causes, though, so we're gonna go through those a little bit here. The most common cause for a sudden cardiac arrest, which we've touched on previously on this podcast, is a condition called hypertrophic cardiomyopathy. It's a genetic malady which causes thickening of tissues of the heart, and it can lead to sudden death. It would have been very difficult. It is very difficult for us to believe that he has not been screened for this over the years.
Right.
This guy is a professional, and that screening probably included EKGs and echocardiograms, and those would have indicated or suggested this condition if it were present. Professional athletes, unfortunately, for better or for worse, they're an investment by the team who's employing them, and the ownership generally wants assurances that the athlete is not a risk for their financial interests.
That's very sad.
It's a sad way to view it, but it's true.
Another reason for a sudden cardiac arrest can be an arrhythmia of somebody who's predisposed. And these are irregularities in heart rhythms, and genetic predispositions can cause some of them. One of them, probably one that people know about more, is something called Brugada syndrome. Mm-hmm. I've had a couple of patients with one of these genetic predispositions, and they got implanted under their chest wall a cardiac defibrillator for life. So if they ever have one, no matter where they are, they can be defibrillated and save their life. I also thought of a few other rare conditions that can cause sudden arrest, like an aberrant coronary artery, which can sometimes not be picked up, even with screening tools. And then there's the one particularly pediatric thing that both of us know, which is commotio cordis, a sudden lethal interruption of cardiac rhythm caused by a sudden blow to the chest, someone whose chest wall is compliant. So this kind of compliance, this non-stiff chest wall, is generally in 8 to 18-year-olds before the cartilage gets calcified. And we've mentioned this phenomenon before, mostly about baseball. That many little leagues are requiring someone to wear extra padding on the front of their chest because baseball can be thrown that can cause commotio cordis. And it's interesting. It's got to be exactly the right thing. It's not really the hardest thrown ball.
Right.
I've heard people say like at 40 to 50 miles an hour hitting the chest. So this 24-year-old muscular man doesn't really fit that. Mm-hmm. But I guess there can be unusual presentations of something that's more usual. But for pediatricians, it doesn't make much sense that was the cause.
Yeah, and then there's the possibility of simply having had a heart attack, from atherosclerotic heart disease. We generally don't think of this type of thing happening to a high-level athlete in his 20s, but it's possible. In today's episode, we're going to discuss atherosclerotic heart disease, mostly in the context of its recognition and its prevention. As pediatricians, we don't deal with heart attacks very often at all, though I know you and I have discussed having patients with Kawasaki disease who have had a cardiac arrest stemming from their coronary artery aneurysms back in the day. Luckily, these events are uncommon now and seem to be even less now 20 to 30 years down the road from the time that we trained.
Right. So So boys and girls, buckle up your seatbelts. We're going to talk about heart disease. But let's go off on a tangent again. So during 2 games ago, a very dismal Eagles-Saints game, I picked up a book that I had on my shelf called Bring Out Your Dead by J.H. Powell. I first thought when I looked at the title it was about the Monty Python and the Holy Grail. Do you remember that?
I do.
About the bubonic plague.
Yes.
Bring out your dad.
Mm-hmm. Bring out your dad.
They bring out that one guy. He's like, I'm not dead yet.
Not dead yet?
He's close. I'm getting better.
Oh, my goodness. I'm feeling better, yes.
But it was not about bubonic plague. It was about the Great Plague of yellow fever in 1793 that hit the then biggest city in the United States. And which city was that, Maddie?
Ooh.
Mr. Kata?
Yeah, yes. That would be our beloved Philadelphia.
Yep.
10% of Philadelphians died during that plague. 5,000 people out of the 50,000 people who were living in Philadelphia at the time. Yes, and it also made me think the COVID-19 epidemic, which occurred over 225 years later, seemed to have some commonalities here. If the mortality rate of COVID had been as high as it was for the yellow fever, then 10% of Philadelphia residents at this point would have been 150,000 people.
Wow.
The yellow fever was initially blamed on foreigners, like the refugees from the slave uprising in Saint-Domingue.
Sound familiar?
It does, yeah.
Right.
Part of the Haitian Revolution. The Haitian Revolution was from 1791 to 1804. This revolution was the largest slave uprising ever and was actually inspired by the French Revolution in 1789. It was tied to having the mixed racial classes, who often owned slaves, wanting equal rights with the white classes, who also owned lots of slaves. But what these two groups didn't realize was that the hundreds of thousands of African slaves in Haiti vastly outnumbered them.
It's incredible, right?
Right? It's like, ruh-roh.
We're purebred. We're less purebred. And then like hundreds of thousands of African slaves. Like, wait a minute, we want something too. So it's a fascinating piece of history. Still reverberates today. The African slaves were eventually free, but as came out a lot in the last couple of years, they were forced to pay huge amounts of money for hundreds of years to France as restitution. And that's one of the reasons why...
Restitution for what?
Right.
Sorry you enslaved me.
Right.
I'll pay back.
We'll pay back the enslavers.
Right.
So it's one of the reasons why Haiti is so poor today compared to like the other part of the island. I think that's Dominican Republic.
Yes.
It's just, I love reading history, and it really helps us understand our world. Yeah. So when people are talking about not allowing certain things in history and certain states in our country are saying you shouldn't teach certain kinds of theories, like, yeah, that's just, it's just horrible.
Mm-hmm.
It just is. So anyway, Philadelphia took in a lot of refugees from Saint-Domingue, including slaves and their enslavers, just as the epidemic of yellow fever started. So fingers were pointed at these groups by Philadelphians. Others in Philly blamed the plague on the then horrible Philly public health conditions, with sewage and air pollution being a big problem. You know, I read that, I was thinking like, oh, is it like the men's room at the old vet?
that was a cesspool. It's like, I'll be right back. I have to go to the cesspool.
And pee on the wall.
Right.
It's one of those troughs that you just pee on the wall.
I remember.
So we now know that neither pollution or unsanitary conditions caused yellow fever, although these environmental risks probably did lead to many deaths from other diseases like dysentery, pneumonia, and tuberculosis.
One thing that really stood out during the yellow fever epidemic was that people desperately looked to the physicians of the day to give them guidance and kind of revered them. Quite different from the fact that many people felt during the COVID-19 epidemic that we couldn't be trusted. You know, this was despite the fact that physicians back then could not help those infected with yellow fever and often made their condition worse.
And no doctor was more wrong on treating yellow fever than the revered Philadelphia physician, Dr. Benjamin Rush, who in many ways was quite a medical pioneer of his time, quite brave in treating Philadelphians, not just the upper class, but some of the poor and slaves. But he was adamant that aggressive treatment with mercury and lots and lots of bloodletting was the only way to prevent yellow fever death. And he refused to listen to advice of doctors from the West Indies, who had actually had much more experience with yellow fever in their whole career. Even politicians like Alexander Hamilton, who was from the West Indies, who had some experience, but he would not listen to anybody who supported less drastic measures of supportive care. And meanwhile, all this time, our founding fathers, I mean, they're no dummies. Washington, Jefferson, they got out of Dodge, went home to their estates to escape the plague. Dolly Madison's first husband died in this yellow fever plague in Philly, and 11 months later, she married James Madison. So if it were not for the yellow fever plague, we would never have had one of our most beloved first ladies, Dolly Madison.
Or the bakery goods that came thereafter.
Isn't that Little Debbie? Did they have a daughter, Little Debbie?
I thought there were Dolly Madisons.
No, there is.
Too,
There is.
I'm not well versed on that. It wasn't until 100 years later that scientists started to make a connection between yellow fever and mosquitoes. Ironically, one of the people who made the mosquito connection credited the discovery in part to notes left by Dr. Benjamin Rush, who wrote that during the yellow fever epidemic, there were an unusually high number of mosquitoes in Philadelphia. On a related note, Dallas, home of the hated Cowboys, has an unusually high number of flies due to all the maggots that live there.
And speaking of that, we would both. Yeah, you put that in there.
I did put that in.
We're both licking our chops. We hope we play Dallas next week.
Bring
the Cowboys.
But back to our story. So, as history would have it, Dr. Rush may have increased the number of deaths due to his faith in bloodletting and by poisoning his patients with mercury, but also may have left clues that permitted scientists a century later to discover what truly does cause yellow fever. Classic irony in the fascinating history of medicine. And we've seen this before, right?
Yep.
This is like a recurring trope in medicine, right? One last Benjamin Rush tidbit. Dr. Rush insisted that people from Africa were immune to yellow fever, and that as such, it was their moral duty to help nurse the sick white people back to health.
Okay.
God. Well, obviously, they had no moral duty to help many of their enslavers, and Rush's scientific presumptions were wrong again. Although Africans did have some protections from malaria, especially, as we now know, if they had sickle cell trait, they had no special immunity from yellow fever, and their death rate was just as high as that of whites.
But honestly, they were a main source of nursing for all of these white people there. So they stepped up. Mm-hmm. They did. So, okay, that was quite a tangent. So now let's talk about lipids or fat, specifically lipids in the bloodstream, some types of which can eventually result in strokes and heart attacks. So in our last episode, we discussed gun violence and the fact that it's now the number one killer of American youth. And it's no mystery, though, that the number one killer of Americans overall hasn't changed in decades, and it continues to be heart disease and atherosclerotic coronary heart disease. It's well known that fatty plaques do damage to the coronary arteries and don't just appear in adulthood. They start forming in children and teenagers and young adults while they're still seeing us, the pediatricians. So logic dictates that the best way to ensure that our patients have long, productive lives is to make sure they don't succumb to heart disease. This idea brings us to the relatively new realm of medicine, preventive cardiology. Now, us pediatricians, we're all about prevention, like when we advocate for safe practices in child rearing or for vaccines that prevent the scourge of infectious disease, and to a large extent, advocating for our patients' heart health has been given a bit less attention. But the fact that cardiac complications are the number one cause of mortality for our patients when they become adults, we need to spend more time focusing on heart health. And I was thinking about that in cardiology. When we were in training, there really wasn't much preventative cardiology. When I think of cardiology training, I think of things like arrhythmias, but also cyanotic heart disease, blue babies. And then it was drilled in us about blue babies. So here's your quiz, Matt. Do you remember the 5 T's of cyanotic or blue heart disease in newborns?
Oh, let me give this one a shot. Tetralogy of Fallot. Those kids tend to have tet spells.
Just know that we're probably going to pause. I'll edit out, so he probably won't get this as fast, but I'm going to let him go as long as he wants. All right, Tet, you got the first one.
Transposition of the great vessels.
TGV?
Yeah, man. Mm-hmm. Which occurs when the relative position of the aorta and the pulmonary artery get switched, more or less. Tricuspid valve atresia. That's
a hard one.
That is. I don't know where I pulled that one from.
I never saw that. I know,
yeah. Truncus arteriosus. Pulmonary artery and the aorta, are kind of together.
One big thing. Okay.
They're kind of fused
One
together.
more left. I'm going to give you time, but this is there's like 5 letters that make up this. Starts with a T.
I don't know this one.
Total anomalous
Venous return.
Venous return.
There you go, man. Uh-huh.
Yes. So bravo. The other scary, life-threatening, non-cyanotic congenital heart disease that's hammered home to us was coarctation of the aorta, which is the narrowing of the main vessel, taking oxygenated blood to the lower part of your body. This can be called duct dependent. So a baby with a critical narrowing or coarctation will deteriorate rapidly when that duct closes. Now, this ductus arteriosus is a vessel that connects the pulmonary artery to the distal aorta in developing fetus, more than anybody out there wants to know, but I got to say it. And it allows most of the right side of the heart's blood in utero to pass the developing lung, because you don't need your lungs when you're in utero. But once the baby's born, blood needs to go to your lungs. But when that duct closes, then if you have certain things like critical coarctation, it can be a disaster, because blood doesn't go to the lower part of your body. Kids kind of crash at 2 or 3 days of age. I remember one was as a resident, and we all thought it was like, respiratory. And one bright senior resident, actually, probably was Dave Thole, he went into cardiology. He's like, this could be his heart. And so
if he went to cardiology, he was always saying, this could be his heart.
Maybe. But it wasn't, or maybe it was Alfie Paul. It wasn't me. I was not the bright person saying that. But and you put him on medication, prostaglandins, so it opens up again until they can fix it. But that was drilled into us. These are important, and we sometimes see these things in our practice. But more and more, a lot of the congenital heart diseases are picked up prenatally and ultrasound. So we're not the ones there when it has to be diagnosed, and I'm happy. But we don't really need.
Those are some scary times.
I know, but we don't need the information that we drilled down. We don't use very much anymore.
Right. So overall, focusing on preventing future heart attacks and strokes in our patients really makes a lot of sense. Luckily, we have doctors like Dr. Carissa Baker-Smith, the director of pediatric preventative cardiology at Nemours and chair of the Atherosclerosis and Hypertension and Obesity in Youth Committee of the American Heart Association. She gave great talks at the Nemours Hot Topics at Disney and at the ROI Warren Seminar here in Delaware this year. We are borrowing heavily from that.
Yep.
And as we always remind people, if we say anything wrong, it's us saying something wrong.
It's us.
She
Mostly
clearly
Matt.
knows what she said.
Mostly Matt.
Usually.
But us, yes. So to start, Dr. Baker-Smith discussed the 8 essential factors in cardiovascular health, some of which are behavioral, like smoking, nutrition, physical activity. There's also weight and total cholesterol and lipids, blood pressure, fasting blood sugars, diabetes risk. And the last factor, number 8, which we love, is sleep quality.
Yeah.
Right? We've started from the first podcast that everything is affected by sleep, and good sleep is great medicine for improved health, including improved heart health. Unfortunately, when we look at young people from 12 to 19 years of age, we're not doing a great job in these 8 areas. 11% of this group have elevated blood pressures, 21% elevated fasting glucose, mostly among the obese, and 46% are not getting enough exercise, 37% are overweight, and a whopping 60 to 80% have poor nutrition with too many fats, too many added sugars, too many processed meats, and too few nuts, grains, seeds in their diet. Now, only 4% are smoking, but that's obviously 4% too many. And as we said, vaping is even much worse than regular cigarette smoking.
And that has to be 4% are smoking cigarettes. Because we know that marijuana, smoking is a lot higher.
And that's not good for you either.
Yeah. So in children within the normal weight range, 25 to 50% can have dyslipidemia. In obese children, the rate of dyslipidemia is much higher. Fatty plaques in arteries of the heart and the peripheral vascular system can start as early as 8 years old. Unfortunately, we know that's from autopsies from kids who died at a young age from some other event.
Right.
One of the things that's very important for us as pediatricians to identify early is whether a child has one of the familial forms of hypercholesterolemia. There is a really scary genetic condition called homozygous familial hypercholesterolemia, which occurs in 1 out of every 300,000 kids. When you hear about a young person who's in good shape and who has a heart attack, familial hypercholesterolemia may very well be the reason, like we mentioned at the top of our show. These patients can often have heart attacks and die before the age of 30. They have lipid levels that are off the chart and which can not be reduced with only the interventions of a good diet and adequate exercise. They need to be started on a statin-type medicine ASAP.
But then there's the much more common heterozygous familial hypercholesterolemia. And this occurs in about 1 in 200. So we're seeing these kids.
Yeah.
It's pretty common. And they have a cumulative risk of having a cardiac event, fatal or non-fatal, by age 60 of over 50% in men and over 30% in women. These folks have a 22 times higher risk for premature atherosclerotic cardiovascular disease. Additionally, their offspring have a 50% chance of having this abnormal gene for familial hypercholesterolemia. So family history becomes a key. So you should suspect this usually heterozygous familial hypercholesterolemia if the LDL is above 190 without a positive cardiac family history, and above 160 if there is a family history of premature disease. And remember, LDL is a calculated value of bad cholesterol. HDL is kind of the good cholesterol. And we need to identify high-risk children sooner than later. This week I had a young lady in college whose LDL was like in the 170s and had some high cholesterol in the family, no early deaths. So they're going to see a lipidologist.
Nice. So that begs the question, when should we screen kids for dyslipidemia? Well, we'll tell you right after the break. We are back. So when should we screen kids for hyperlipidemia? Well, it's recommended that we do a lipid panel in children between the ages of 9 and 11, and then again between 17 and 21 years. But if there's a family history of high cholesterol or premature cardiac disease or significant obesity, then we should begin screening as young as 2 years old. And what, Roberino, is a qualifying family history, you ask? Well, if there are... It sounded like you were ready to tell us. Well, if there are men in the family who have had a heart attack under 55 years of age, or there are women in the family who have had a heart attack at less than 65 years of age or younger.
And I don't know, if I know that there are close relatives on statins for high cholesterol at an early age, I'll screen that child early. I don't know about you, but even if there are grandparents or parents in their early or low 60s with a history of heart attacks, I consider that a big risk factor. Now, they'll tell us in the room, well, they were smokers, they had diabetes, they were obese, but if they had heart attacks that early and stents, I'll screen early on those too. And when taking a cardiac history, sometimes I'll find out there's multiple generations of family members who suffered early heart attacks, especially in the men. And I do spend time in the room when that happens, looking at dad saying, you need to see a cardiologist, or mom saying, you need to text dad now, even if they haven't. Have you done that? Like, dude, you got to see a cardiologist.
Well, like so many other things in pediatrics, we kind of we reveal things through our history, and they're like, yeah, you might want to get yourself checked out.
Yep, yep. I think we've both had too many relatively young dads in our practice die of heart attacks. And if there's a multi-generational trend of early heart attacks in the family, I don't care what their cholesterol is, they should see a cardiologist.
Yeah. Other kids to screen early in life because they're considered to be high risk include those with obesity, with diabetes, with hypertension, chronic kidney disease, a history of Kawasaki's disease, or chronic inflammatory conditions. We can begin doing lipid screens, as we said, as young as 2 years old, if it's applicable.
Now, we did a hot controversy debate a few years ago at Disney, as you recall, Maddie, about should we be screening every 9 to 11-year-old child if they have no risk factors at all? It's an interesting debate because studies show most pediatricians have not been doing that, and we fail to follow these guidelines and look at what the cost-benefit ratio is to do that. But I know, and even doing research for this even more so, that I am routinely going to do that more. How about you?
Yeah, same. I tended to fall on the side of the folks who were disagreeing with the recommendation back during that Hot Topics debate, because it's one of those things where, what's the yield here unless there's clearly a family history? Well, as you pointed out, sometimes the family doesn't know its own history, right? And so in that context, it does. It called me out. It really did. And I think that, moving forward, it's necessary for us as pediatricians to take this as part of our job. We need to be ensuring your health. It's not just like, okay, you're 18 or you're 21. Hey, have a nice life. Like we should have been involved with this aspect of it before.
Right. So I'll do it around 9 to 11 years old. If I have a girl who hasn't hit menarche yet, and I might say, okay, let me wait a couple years and then I can get a CBC and get a ferritin if there's no risk factors. So I can do all those at the same time because they're more high risk for iron deficiency. But what's the question that we need to ask?
Yeah, I mean,
Matt?
it begs the question, what exactly should we order for screening, right? We talked a few minutes about clarity. Well, let's get clear on this, right? The official AAP guidelines state that if there are no risk factors, then the test to order is a non-fasting total cholesterol and an HDL cholesterol. Once you have these results, you then subtract the HDL from the total cholesterol to get the non-HDL cholesterol. That is the number that we need. We want the non-HDL cholesterol to be less than 120 in kids and the total cholesterol to be less than 170. It would be optimal if the good cholesterol, HDL, is greater than 45 and if the LDL is less than 100. But I was surprised to hear that Dr. Baker-Smith prefers that we order a fasting lipid profile. This profile, in addition to checking the total cholesterol and the HDL, also includes LDL and the triglyceride level so that a broader picture can be interpreted.
And she likes to use the LDL value to determine decisions like referrals and treatment of hypercholesterolemia. So I have started getting fasting lipid panels on these younger 9 to 11-year-olds instead of just the non-fasting cholesterol and HDL. And I thought initially that would be a big sticking point, like, we don't want to skip breakfast, but it doesn't seem to be any issue skipping breakfast. But then, as best practices often are evolved, more and more studies have indicated that fasting may not be that important when we get a lot of these lipid tests. Eating before we do a lipid draw does not affect really much the total cholesterol or the HDL or the LDL much, although a big meal can affect the triglyceride level. I still try to tell them to fast when I'm doing the lipid panel, but if they forget, unless the triglyceride's really high and I'm wondering about it, it's usually going to be fine. And of course, there's other causes of hyperlipidemia: thyroid disease, kidney disease, diabetes. Some medications can elevate them. We've talked about Accutane, which can elevate them and the triglycerides, and we have to keep those in mind.
Okay, so we get the lipid results. We know by the research done that about 20% of kids between the ages of 16 and 19 will have at least some abnormality in these tests. The most common cause of really significant elevations in lipid levels is the heterozygous familial hypercholesterolemia that we just discussed. With some of these results, it could be obvious that a child needs to be referred to a preventative cardiology specialist. Again, remember that 1 in 200, or 0.5% of the kids that we screen will have this condition. It's a relatively small slice of our patient population, but identifying them early can make a huge difference for their future health. There's also familial combined hyperlipidemia. This condition is one of the more common reasons for a person having elevated triglycerides, which also will increase the risk of heart disease.
And then there's the type of dyslipidemia that occurs with obesity. In this situation, it's a classic pattern of elevated triglycerides coupled with a really low HDL. We both see that, right, when we do our screening of obese children. And speaking of the overweight obese kids, we also need to be on the lookout for early diabetes in these children, with lab findings of elevated glucose and elevated hemoglobin A1C and evidence of fatty liver disease, also known as non-alcoholic fatty liver disease, or NAFLD. Now, medicine is not that great on nomenclature, and I think we both realize that this is a terrible term to use since these obese kids are not like thinking that they're having chronic alcoholism. Mm-hmm. And no one asks us on naming it, but we like to shout out some other good podcasts out there. So I did recently hear a podcast on this, on something called Cribsiders. It's out of, I think, Hasbro Children's in Rhode Island, mostly hospitalists. And they noted that fatty liver disease in obese kids can start as young as 9 years of age. So it's the perfect time to screen for this disease when we do our lipids at 9 to 11. Checking a liver enzyme, generally just the ALT, the old SGPT, is enough when we're checking it. And if you consider fatty liver disease, if it's above 80, that's likely, although some would say above 50 is also qualifying for fatty liver disease. I've seen this especially when kids rapidly gain weight.
Me too. Yeah, and having a fatty liver can lead to liver inflammation and even to cirrhosis of the liver and liver failure. So this condition can really be a big, bad deal. It's interesting that when we tell some parents that their child's cholesterol is high, that this leads to increased cardiac disease risk down the road, it doesn't often get their attention. But when we talk about fatty liver and liver inflammation from being overweight, it seems to make them more likely to be eager.
Right.
Yeah,
They
to make
all of a sudden
healthy changes. Yeah, it's interesting the way that people, what's important to people, right?
Right.
We find that whatever way we can present the circumstances and have the kids eat a healthier diet and get more exercise is a win for them and for their family.
And that Crib Cider podcast also made a really good point that if the liver enzymes are elevated in an obese child, you shouldn't always assume that it's due to their obesity. And one of our favorite mantras has always been there's a difference between causation and correlation. And just because findings or observations are present, it doesn't necessarily mean they're linked. So in this case, to automatically assume elevated liver enzymes is always just from obesity in these kids can cause us to miss other causes of liver disease like infectious hepatitis, autoimmune hepatitis, or thyroid issues. There's also rare causes like Wilson's disease, which is a storage disease of copper, or alpha-1 antitrypsin deficiency, which is a lack of an important enzyme. Actually, a few months ago, I had a college student who was overweight and was doing a screen including liver enzymes, and it was elevated, but much more elevated than I would have thought. And so I did some research on where do we do research?
Up to date.
Up to date. Again, we have no connection with them, and it's a treasure trove of cutting-edge comprehensive medical information. And I looked at that, and in the list of things to check for when the liver enzymes are high included looking for celiac disease. And this young lady didn't have any history, so I threw in a TTG and IgA there, and it was off the scale.
Wow.
And she had celiac disease, and that's probably why her liver enzymes are increased. And of course, it's kind of sometimes better to be lucky than good. I wasn't thinking of celiac disease, but as Matt says, and Benjamin Franklin somebody says, luck favors the prepared mind.
The prepared, yeah. I think it's
mind,
luck favors the prepared, something like that.
Something like that.
Yeah.
Yep. Yeah. Not smart.
Yeah, so we use up to date all the time. Next question, when should we refer our patients to preventative cardiology? Well, if you're talking about dyslipidemia, Dr. Baker Smith says that a child's total cholesterol over 200, or the LDL, or bad cholesterol, is greater than 130, or if the triglyceride level is greater than 130, or the non-HDL cholesterol is greater than 145, then a referral is appropriate. I certainly have had some teenagers mostly overweight with cholesterol levels greater than 200, but with their LDL being in the normal range that I've not referred, and instead have had them focus on being conscious of improving their nutrition and increasing their amount of exercise and then repeating their lab work prior to necessarily having them see a preventative cardiologist. How about you, man?
Same thing. We'll get some that are above 200 and the rest of them aren't that high. And I know in the past if they see the cardiologist, they'll say nutrition, exercise. They're not starting statins yet. So I'm comfortable saying, okay, let's start this ourselves and do some lifestyle changes. Dr. Baker Smith also made a point about hypertension and that we should be referring kids between the ages of 6 and 12 who have a manual blood pressure greater than 130/80. Although, as we know, you need to do multiple blood pressures because sometimes it could be inaccurately high if there's something called white coat hypertension, where they're kind of nervous when it's squeezing their arm. So we don't try to send them after a single blood pressure reading, but we also got to make sure that we're using the right size of cuff. And also, if there is a high blood pressure with any history of kidney issues or prematurity, that is a reason to refer these kids quickly, which gets to that divide we've talked about, like where are you going to send them? Do you send them to cardiology or you send them to nephrology? Because a lot of hypertension in young people are due to kidney issues. And she liked to use that if there's any other kidney disease or they're premature, or if the child's under 6, then go to see nephrology. Otherwise, it might be better to see cardiology. And I think that's a good rule of thumb.
I think that's a good rule of thumb. Lastly, Dr. Baker Smith touched on basic treatments for hyperlipidemia, particularly the variety of statin medications that could be considered, especially for those with familial hyperlipidemia, drugs like generic Crestor and Lipitor. Many of the more recent recommendations for using statins in adults are becoming more age-based, so most men in their 60s and 70s will end up on some type of a statin. As much as both of us are expanding our repertoire of prescribing psychiatric meds and hormones, I think we're still leaving the statins to the specialists for now.
Yeah, me too, right?
Yeah.
I don't really have a big interest
No.
of doing that. And I ended up on a statin last year, even though my total cholesterol was under 200, just aging into it and such. It's kind of a pain, a little bit of muscle aches, take it every few days. But my lipids went way down. Have you gotten to that point yet, Maddie?
Lab work pending.
Oh.
No.
maybe not going to
Right,
Wawa every day might be helpful.
Hey,
Yeah.
no, my sore point is pretzels and cheese at night. Yeah. Now, as for dyslipidemia in children, when the level is not severely elevated, including situations where the dyslipidemia is related to a child's obesity, with increased triglycerides and decreased HDL, starting omega-3 fatty acids, decreasing sugars and carbohydrate in their diet, and increasing the level of exercise is the first-line treatment. We should stress that increasing omega-3 fatty acids throughout childhood is hugely helpful. So studies show this. There are a lot of things out there like, this looks like it could help. This looks like it might help. This is unequivocally helpful. Right. And that a great source of that compound is oily fish, eaten about twice a week. These oily fish superfoods include salmon, sardines, cod, herring, and light tuna. And I'm trying to mention this recommendation more often to the families in my practice. Obviously, fruits and vegetables, whole grains, and high-fiber foods are also all great. As a side note, since we see many moms who are pregnant, we may want to mention to them that there are some fish that are likely to have high levels of mercury, like shark, swordfish, orange roughy, and some types of sea bass, that they should look to avoid during their pregnancy and to avoid giving to their young children. This, of course, would be ignoring the advice from our friend Dr. Benjamin Rush that a good dose of mercury could help you fight yellow fever.
But those other fish and the salmon, it's great for pregnant women. And I did look up shrimp and lobster because I like them,
right.
And they are a pretty good source of omega-3 fatty acids. Not when you put like buckets of butter on them, which I often do. Crabs a little bit less, but I love me some my blue crabs.
Yeah,
how about you?
Just had some shrimp scampi last night.
I do have a few patients on prescription strength omega-3 fatty acids to treat high triglycerides. And this can be considered for certain high-risk people with triglycerides above 300 or certainly 500. And if it approaches 1,000, it can cause pancreatitis. One of the ones my patient's on is called Lovasa. But I think more and more of these meds will be coming out in the future, as we mentioned before. And then there's the newer obesity drugs, like the weekly injectable semaglutide, which is called Wegovy, that is becoming more available to our patients over about age 12. And again, we talked about this before, but this may be a game changer for obesity. And the new AAP guidelines for obesity just dropped after 15 years and may signal a sea change in our approach to this epidemic obesity problem.
These new guidelines, which were rolled out by none other than our very own Delawarean and former president of the AAP, Dr. Sandy Hassink.
Sandy Hassink, I think only Aubrey Plaza is more well-known Delawarean right now and more in the news than Sandy Hassink.
True. At least in our minds, right?
Right.
Yeah. So I had the pleasure of working with Sandy, a delightful person. In fact, I would go back time and time again on my electives. Yeah. I would go back and see Sandy because I thought that this is good work, right? So in young overweight children, moving more toward aggressive interventions, treating obesity in a fashion similar to the way that we treat other chronic diseases like asthma, since obesity has so clearly proven to lead to long-term problems like heart disease and diabetes, and since obesity affects over 14 million children in America. Astounding. Many of the guidelines include very intensive behavioral and lifestyle interventions with coaching on nutrition, physical activity, and behavior. Implementing this approach will require a lot of resources. So just because we think this is a great approach doesn't necessarily mean it's going to be abided by or funded.
Right.
Yeah. And after this intensive therapy, then weight loss drugs should be considered for adolescents as young as 12, according to the report. And those 13 and older with severe obesity should be evaluated for weight loss surgery. We're definitely going to need to dive into this more in a future episode.
Yeah, we will. But really the key factor for most of our pediatric patients now with moderately elevated lipids is stressing the increased exercise and specific foods like we talked about, but just changing their eating lifestyles. And nothing has been studied more and found to be more successful in eating lifestyle than the variations of the Mediterranean diet. And since it was first looked at in the famous 7 countries study starting in the late 1950s, nothing's proven more beneficial than the food habits that are often seen around the Mediterranean, countries like Italy, Greece, and Croatia, which have diets rich in fruits, vegetables, legumes, whole grains, nuts, seeds, fish proteins, and healthy fats. It's not a quick bookmaking Dr. Oz type diet invention. It actually evolved over generations, and a big part of it is because it tastes yummy. And this was nicely written about a few weeks ago by Danny Blum in the New York Times.
Yes, it really encourages high omega-3 fatty acid fish like salmon, sardines, and tuna as the preferred animal protein, but it includes other lean animal proteins like chicken and turkey as well. Red meat and butter can be added, but rarely, and eggs and dairy products like yogurt and cheese can be added too, but in moderation. Even alcohol for adults in moderation, like a glass of wine at dinner, is fine according to this diet. Besides reducing the risk of cardiovascular disease by 25%, the Mediterranean diet also decreases neurologic diseases and cancers, and likely reduces the risk for type 2 diabetes too. It also greatly promotes a healthy pregnancy. Don't think of it as a diet. Think of it as a lifestyle. And since it has less red meat and dairy, make sure you get enough iron from nuts, legumes, spinach, broccoli, and get the vitamin C from fruits so you absorb that iron. With less dairy, make sure you're getting enough vitamin D and calcium, perhaps with a supplement. Have you tried this, Roberto?
Actually, I've tried to gravitate towards this, and of course, better sleep and exercise. But again, it's what we eat that's the number one factor. And as you said, you can still get your occasional Philly's cheesesteak, and for you, Matt, your tasty cake too. But if you're mostly doing the principles of the Mediterranean diet, it's just going to make you live a lot longer. And we want you to live forever, Maddie. So that's all we got for now, boys and girls. Our next episode will be on blood, anemia, iron deficiency, bleeding. There will be blood.
There will be. What a great movie.
There will be blood.
Underappreciated.
Yes. We'll talk about it.
Yeah.
All right. Say goodnight, Maddie.
Good night, Moon.
Okay. Let's do it for all the people out there. Fly.
I thought we were going to do the Eagles. Okay. Ready?
Fly, Eagles, fly on the road to victory. Fight, Eagles, fight. Scoring touchdown, 1, 2, 1, 2, 3. Hit 'em low, hit 'em high. Watch our Eagles fly. Fly, Eagles, fly on the road to victory. EAGLES, Eagles!
Yeah, man.
Podcast Pediatricians Productions. All rights reserved.